Good evening, everyone. I am Dr. Vishwanath S. And we welcome you all to this webinar on ALK-positive advanced non-small cell lung cancer from the CPOM Foundation. And today we have Dr. George Simon, the Executive Director and Chair of Medical Oncology from Moffitt Cancer Center, Florida. Along with that, we also have Dr. Santosh giving his talk. And our educational grant is by Pfizer Oncology and MedGenome. So our keynote speaker for today is Dr. George Simon. He is the Executive Director at the Moffitt Cancer Center in Florida. And his main area of interest is non-small cell lung cancer, thymoma, mesothelioma, and he's got extensive experience in this field. And he's been a principal investigator in numerous clinical trials. And he's also been a professor in the thoracic oncology at the MD Anderson Cancer Center in Houston. And he's also been a medical director at the MD Anderson Cancer Center in the thoracic oncology department. We welcome you, sir. And Dr. George Simon will be giving his talk on sequencing of ALK inhibitors in advanced non-small cell lung cancer for ALK positive, and also the mechanisms of resistance of ALK. Welcome you, sir. And we request you to give your talk.
Thank you, Dr. Vishwanath, for that kind introduction. I'm going to go ahead and share my screen.
Sure.
And okay, so welcome everybody to this webinar. I'll be talking about ALK inhibitors and how we can mitigate some of the resistance mechanisms that we can see while we treat patients with ALK inhibitors. I believe there may be quite a few DM students in this group, so I'll start with some basic ALK information and then go on to a little bit more detailed information about treatment strategies. As you all know, ALK is approximately 8% of adenocarcinomas and is as is shown here in this slice of the pie. And if you take non-small cell lung cancers, it's really more, let me see if we can move forward. Okay. Yeah, in non-small cell lung cancers, if we take all non-small cell lung cancers, it's about 4%. Now, what is ALK? ALK is actually a normal gene. It is a gene that promotes division of cancer cells, division of normal cells. And what happens in cancer is that the actual gene that is designed to promote cell division comes in proximity to another gene that acts as a promoter and constantly keeps the gene on instead of switching on and off based on a ligand receptor interaction. Okay. So ALK actually lives on chromosome 2. And one of the aberrations that happens is an inversion. And so what happens is during that inversion process, a promoter gene or a switch comes in close proximity with the ALK gene, and then the ALK gene gets continuously turned on. The second aberration is a translocation, usually from chromosome 5. ALK lives on 2. And some chromosome 5, a segment can be detached from chromosome 5 and then attached to chromosome 2 in proximity to the ALK gene turning it on. And then you have this constant on signal releasing the ALK from the dependency from a ligand receptor interaction. And this keeps the cell cycle going incessantly and leads to uncontrolled proliferation of these cells, which is basically cancer. So we now know that ALK has got several partners, and the most common partner is EML4. So ALK is the oncogene, EML4 is the promoter, and the breakpoint in EML4 can be very different. So EML4 is a long gene and it can break at multiple points. So the fragment length of EML4 attached to the ALK can vary from patient to patient. And And the significance of that is not clearly understood, whether it's a more potent driver in certain situations or less potent driver in certain situations is not entirely clear. But we see this often, that the fragment length of EML4 can vary. There are other fusion partners other than EML4. There's TFG and there is KIP5B RET. And KIP5B is a common RET partner. KIP5B is a promoter, and we can see it commonly fusing with a RET oncogene to give the KIP5B RET fusion, but occasionally it can be fused with ALK as well. So those are some of the translocations, inversions, and aberrations that can turn on the ALK gene. How does ALK really work or signal? So what happens normally is that there is a ligand that interacts with the receptor, which leads to phosphorylation of the intracellular tyrosine kinase domain, which then leads to activation of several pathways. The JAK-STAT pathway, which is a pro-growth pathway. It can lead to the activation of PI3 kinase AKT pathway, which is an anti-apoptotic pathway, and it can lead to activation of a MEK-ERK pathway, which is also a pro-growth pathway. So that's what normally happens. Now, when you have a fusion with a EML4 ALK or any other fusion partner, what happens is the receptor does not have to be activated by the ligand, and the receptor becomes independently activated of the ligand, and it is constantly turned on. ALK is actually a developmental gene. That means it's turned on during embryogenesis. And then once the organs are formed, the ALK is turned off. And most of our adult life, the ALK is turned off. But in certain tumors, it gets turned back on because of the molecular aberration that happens. Now, unlike EGFR is almost exclusively seen in lung cancers. ALK actually is seen in a variety of other cancers. And these cancers are commonly called, often referred to as ALKomas. Okay, so obviously ALK is called anaplastic lymphoma kinase. That's what ALK stands for. And as the word implies, it was first described in anaplastic large cell lymphomas, and then subsequently described, a US group described it in lymphomas, and then a Japanese group described it in lung cancer. And then, of course, it's also seen in a variety of other cancers. An interesting tumor is interstitial myofibroblastic tumor. This is actually a pleural-based mass, and you may see this in your clinic. A large pleural-based mass sometimes can mimic a mesothelioma, and 50% of these will have an ALK translocation, and they're responsive to ALK inhibitors. But as you can see in this list here, there are some rhabdos, some colon, some breasts, some renals, some neuros, some anaplastic thyroids, Spitz tumors that also can express ALK. So this sort of highlights the importance of doing next-gen sequencing, because when you do next-generation sequencing in a variety of tumors, you may get lucky and identify a targetable molecular aberration, even outside of the so-called common diseases where these molecular aberrations are typically seen. So, the important point, the one thing to remember about this slide is that, yes, ALK can be seen in other tumors other than non-small cell lung cancers, like KRAS. As you know, KRAS can be seen in lung, in colorectal, in pancreas, and a variety of other cancers. Now, one of the earlier tests for ALK was called a break-apart FISH. So what happens here in break-apart FISH is you take one probe and color it red, and you attach it to the ALK gene, and you take another probe and color it green and attach it to the EML4 gene. And then when the two probes are attached by FISH, fluorescent in situ hybridization, then normally you should be able to see two different signals because they are apart, like a red signal and a green signal. But if there is a fusion, the red and the green come together and to give you a yellow signal. And that's the reason why it's called a break apart FISH. And the yellow signal suggests the presence of a fusion. FISH is sometimes, it's not widely available in many of the centers. And so people have developed other techniques to detect ALK. And the most common other techniques used are immunohistochemistry. The antibody is D5F3 with a 95% sensitivity. And of course, I think the gold standard is next generation sequencing. Next gen sequencing will tell you, everything. It tells you what the fusion partner is. It tells you what the length of the fusion partner is, whether it's an inversion or a translocation, and that's about as very highly sensitive in the 90s. And there is a lot of concordance between next-gen sequencing and IHC and FISH. Break apart FISH is a little bit more difficult to do, and it's seen in about 82% of the patients. Now, sometimes I've seen situations in the clinic where you can, for the world, you think that this patient has a molecular aberration somewhere, usually adenocarcinoma, never smoker, mucinous features, youngish male, and you think this patient is smelling ALK, but next-gen sequencing sometimes can come back negative. And some of those situations I've repeated a IHC, and that can sometimes give you clues. And IHC can be easily done in many of the conventional pathology laboratories in across the country. Now, the first drug that came along was Crizotinib, and Crizotinib was a drug that was actually developed as a MET inhibitor by Pfizer, and it was being developed as a MET inhibitor in the United States and the United Kingdom. And then when the ALK gene was discovered in lung cancer, it was quickly repurposed as an ALK inhibitor. And, and this is the first study that showed that in the ALK setting, an ALK inhibitor can beat chemotherapy, which was the standard at that time. And I'm talking back 2011, 2012, and a pill beat doublet chemotherapy. This is the so-called Profile 1007 trial, progression-free survival curves, and there was no contest. The median progression-free survival was 7 months versus 3 months, 8 months versus 3 months, with a very significant hazard ratio and p-value. So essentially, that established Crizotinib, which was actually serendipitously found and discovered to be an ALK inhibitor, became the standard first-line treatment for non-small cell, ALK-positive non-small cell lung cancer back in 2012. Subsequently, we developed second and now third generation ALK inhibitors. And this has led to a plethora of drugs. The next drug that came along was Crizotinib, and all these studies actually took Crizotinib as a standard and pitted was the drug versus Crizotinib. So Crizotinib, the Ascend-1 through to Ascend-4 studies looked at Crizotinib versus Crizotinib. The Alectinib studies, the ALEX, the JALEX, the North American ALEX and the Japanese JALEX trials looked at Alectinib versus Crizotinib, and the ALTA-1L study looked at Brigatinib versus Crizotinib. And then Lorlatinib study looked at the so-called Crown study, looked at Lorlatinib versus Crizotinib, and then most recently the EXALT-3 trial looked at Ensartinib versus Crizotinib, and then there are other drugs like Entrectinib and a few others still in looking at this space. But the bottom line is the second generation and third generation inhibitors were significantly more potent, more effective than Crizotinib. And so that's sort of highlighted in this slide here. Here I've picked a few slides. One is the ALEX trial, alectinib versus crizotinib, the ALTA-1L, which is brigatinib versus crizotinib, EXALT-3, which is ensatinib versus crizotinib, and the CROWN study, that's lorlatinib versus crizotinib. And the bottom line here, as this arrow indicates, is that in all of these studies, the progression-free survival was just dramatically better for some of these agents compared to crizotinib, usually in the 3-month range, give or take a few months. Here's here in ALEX's 36-month PFS rate was 46.4% for alectinib versus 13% for crizotinib. In ALTA-1L, it is 45% versus 18%. EXALT-3, we don't have a 36-month follow-up yet, but otherwise at the 27.6-month range, it appears close. And in CROWN, the 36-month rate was 63% versus 18%. So in all of these agents, beat crizotinib handily, and many of these agents, including ALEX and ALTA-1L, there was an improvement in overall survival as well. So this led to these drugs, alectinib, brigatinib, lorlatinib, all being approved for first-line treatment of advanced stage non-small cell lung cancer in the United States. Okay. So here are some comparisons of the responses, the overall response rate comparisons. Lorlatinib was 77.2%, brigatinib 74%, alectinib 82%. So, I mean, these are just sort of different studies that, you know, essentially comparable. And these newer drugs also had a high intracranial response. So they also penetrate the blood-brain barrier. There was a high intracranial response, as you can see here, in patients who had more than one measurable disease. You can see lorlatinib had an 83.3% response intracranially. Brigatinib had a 78% response, and alectinib had 81% response. So these drugs are incredibly effective in the brain as well. But they have some side effects. Some of the sine qua non side effects for all these agents is, you know, they tend to have a pedal edema, and you see it in most of these drugs. But in lorlatinib, there are some critically different side effects. One is hypercholesterolemia. So most of these patients would need to go on a medication, a statin, to reduce cholesterol levels. They all can also have peripheral neuropathies and mood changes, cognitive effects, including some patients can have encephalopathies. So lorlatinib is, in my opinion, and my hands, a little bit of a harder drug to give than alectinib or brigatinib. Alectinib can cause some anemia, myalgias, you know, some liver enzyme elevations. Brigatinib, again, the sine qua non there is pneumonitis, you know, and so that's why you start at 90 milligrams and then go to 180. And then it can also cause increased lipase elevations and increased CK elevations. And ensatinib is actually reasonably well tolerated with some rash, pedal edema, occasional diarrhea. But as you can see, there are some common class toxicities, but there are also some drug-specific toxicities that you can see with these drugs. Okay, so what I do in my practice is I usually start with alectinib or brigatinib, and then switch to a different TKI, and that really depends on, you know, what resistance mechanism I'm able to identify, if I'm able to identify a resistance mechanism. Okay, so what are the common resistance mechanisms? The common resistance mechanisms are amplifications or ALK fusions, amplifications of the ALK gene, mutations in ALK kinase domain, and we'll spend quite a bit of time on that. Sometimes the cells can undergo transformation into small cell and occasionally squamous cell. And then it can activate other bypass signaling pathways, usually MET, c-KIT, IGF-1R, or EGF. KRAS. So if you are able to identify which one of these is responsible for the resistance mechanism, you could potentially treat them for that specific resistance mechanism. Now, small cell and squamous cell transformations typically are seen in patients who have P53 and or RB. So if you have a patient with an ALK translocation and the next-gen sequencing shows a P53 mutation as well as an RB mutation, then you worry about the transformation happening in small cell transformation. If it is more P53 only, then you could worry about having a transformation into a squamous cell. Bypass signaling pathways can be identified sometimes, and then you use the specific bypass inhibitor. And for EML4 ALK amplification, we don't have a good treatment strategy yet. People have tried HSP90 inhibitors, chemotherapy combined with the TKI, some of the options that we use there. We'll spend bulk of our time here in the mutation space because this is where we can actually effect some change in our therapeutics. So basically what happens with these mutations, so these are Crizotinib resistance mechanisms, right? So these are all happening in the ATP binding pocket of the tyrosine kinase, okay? And this is basically when you say L1152R, basically the leucine residue is removed and substituted by an arginine residue. So that's basically what it means. Leucine is taken out and arginine, and the drug therefore cannot fit. And, it could be a steric hindrance problem, a 3D-dimensional steric hindrance problem, or a covalent binding problem. But for some reason, the drug is not able to actively fit into the ATP binding pocket and shut down the signaling, okay? So these are some of the common mutations seen in ALK translocations treated with Crizotinib. Now, some of these mutations, if identified, can be sensitive to other specific drugs, okay? So here are some of the resistance mutations and that are inhibited by the drug Crizotinib, both in vitro and in vivo studies, okay? One principal and recalcitrant mutation is G1202R. There's only one drug we have right now that inhibits that, and we'll get to that in a minute. But this is a difficult mutation and not so uncommon mutation that can be seen. And here, this is a patient-level information. Patient was given Crizotinib, she responded, progressed after 34 months. They found a mutation that was sensitive to Crizotinib, and then responded to Crizotinib and then progressed on Crizotinib eventually. So you can find these resistance mutations which you can eventually target, okay? So this is another case report of a patient who was treated with first with Crizotinib and then with Alectinib, and then gets this is an Alectinib resistance mutation. We often see this mutation in patients with Alectinib. And this mutation is actually sensitive to Crizotinib. So once we identify that this is a patient after Alectinib, pre-Crizotinib, big liver metastases, and then on Crizotinib, you can see the metastases are shrinking. So sometimes you can, go back forth between the TKIs to ensure resistance, okay? And there are other Alectinib resistance mutations. This is another case report of a Alectinib resistance mutation that was treated with Crizotinib, which responds, as you can see in some of these CT scans. And this is a patient with MET amplification, okay? And this patient was treated with Crizotinib. So the patient was initially treated with Alectinib, MET amplification was identified, and then remember, Crizotinib was developed initially as a MET inhibiting drug. And now we have better MET inhibitors, Crizotinib, Cabozantinib, Tepotinib, Capematinib, which may be other choices. But here again, a resistance mechanism was identified, which was targetable. What happens when you use very potent drugs like Brigatinib or Lorlatinib? And here, it's this when you have a very potent tyrosine kinase inhibitor like Brigatinib or Lorlatinib, you can see that you get multiple mutations. And that we commonly see with Brigatinib and Lorlatinib. It's sort of a shotgun. The tumors create multiple mutations, completely altering the inner binding pocket of the tyrosine kinase, making the drug difficult to bind. And therefore, these patients sometimes will have to be treated with chemotherapy first, and sometimes can be treated with combinations like lorlatinib, crizotinib in this case, to target those inhibitors. And they can be very difficult. This is a lorlatinib progression, and on lorlatinib, they get these two different mutations that came on lorlatinib, making it very difficult to target these mutations. So with the more potent tyrosine kinase gets, the more the number of mutations it needs to survive the selective pressure of the drug, as shown in this curve. Now, lorlatinib was actually specifically designed to target those ALK translocations and mutations where the leucine residue is lost. Okay, so it was one of the common resistance mechanisms where I see here the leucine residue is lost here and residues are lost here. And this drug is, was designed to really bypass this common resistance mechanism as shown in this paper. And if you look at this, so this is a sort of similar to an antibiogram that you have. And these are the various mutations here, and these are the various drugs, and these are resistance sensitivities. And you can see that here leucine was lost for an arginine, and it is sensitive to lorlatinib. Here again, leucine was lost for a methionine and sensitive to lorlatinib. But then there are some that are even resistant to lorlatinib. This one right here, resistant to lorlatinib. Now, G1202R is one of the problematic mutations that we see. And the only drug that is sensitive to G1202R is lorlatinib. And it's, one of the specific drugs that we specifically use in the G1202R setting. So, and this methionine residue is a common thing that we see across multiple tumor types. If you see, when you develop resistance to c-KIT, the methionine residue happens on a amino acid is replaced by methionine in GIST and other tumors. Even in EGFR, one common EGFR resistance mechanism pre-osimertinib was T790M, that M is methionine. And methionine is sort of a bulky, physically bulky residue. And it sort of, alters the binding of the TKI in the pocket, either causing a steric hindrance or changing the binding constant of the drug, and therefore affecting its ability to shut down the pathway. So, and these are some specific mutations that we are pointing out where lorlatinib data are not there. This is one specific leucine loss mutation where there is resistance. Now, another tactic that we have used, and this is when I was at MD Anderson, we participated in this study. So we took these patients and treated them. So you give, these are not specific to EGFR or ALK, these are non-small cell lung cancer stage 4. We gave them frontline therapy, and we reduced in responders, patients who responded, we reduced the bulk of the disease as much as possible. And then patients were randomized to continuing maintenance therapy as would be the standard, or giving some local consolidative therapy. That means you started out with 5 metastatic lesions, you gave whatever induction therapy you wanted to give, and you're left with 2, which are persistent. Then what you do is you kill those 2 off with radiation or sometimes surgery. You destroy those with radiation, and that's called local consolidative therapy, and whether that would improve survival. And so this was a sort of a randomized phase 2 study trying to understand whether local consolidated therapy after maximal response, after induction therapy, whatever that is, chemoimmunotherapy, or targeted therapy would improve progression-free survival or survival. And so here the definition of first-line therapy here for more than 4 cycles of a platinum-based doublet, if the patient did not have any targetable molecular aberrations, or 3 months of erlotinib, afatinib, gefitinib, osimertinib, alectinib, depending on, osimertinib, depending on the patient has EGFR mutation, or 3 months of crizotinib. This was the only drug available at that time when the study was envisioned. And what we did see was that giving local consolidated therapy significantly improved progression-free survival compared to not giving local consolidated therapy, with the median PFS in the no LCT arm was 4 months, and in the LCT arm was almost 12 months. And when they did a subset analysis, what we found here in this right panel is that the EGFR ALK subset are the ones that really seem to benefit by local consolidative therapy. And I've tended to use this in my practice. So what I do is I give them a TKI, get a maximal response, and then if there are 1 or 2 lesions left, I go and hit them with stereotactic radiation therapy and kill them and continue observation on the TKI. Now, if you're using chemotherapy, and almost every patient, you'll wind up eventually using chemotherapy, the one chemotherapy drug you have to use is pemetrexed. ALK-positive disease is sensitive to pemetrexed. And here you can see that this is pemetrexed platinum, and the ALK-positive disease is the most sensitive compared to wild type and compared to KRAS-positive disease. And this has been shown in other studies as well, where the ALK-positive line here is the most sensitive, even better than the EGFR-positive lines. As you can see here, ALK is here, wild type, both wild type is here, and EGFR positive here. So there seems to be some differential and preferential sensitivity to pemetrexed-based chemo for ALK positive patients. And we don't know exactly why, but one of the potential explanations for that is thymidylate synthase, which is the principal enzyme that is targeted by pemetrexed, is very low in ALK positive patients. And response to pemetrexed really depends on thymidylate synthase levels. High TS levels, responses or PFS are low. Low TS levels, responses and PFS tend to be higher. And that has been validated in several of the cell line models as well, where the most sensitive is where TS is very expressed in very low numbers compared to higher sensitivity. So if and when you do have to use chemotherapy, make sure that pemetrexed, whether it's carbopemetrexed or carbopemetrexed, Avastin, is in the initial regimen. And this is just a quick reminder that many of these ALK inhibitors also target other molecular aberrations, RET, ROS1. Seritinib also targets IGF-1R, and entrectinib targets TRAC and ROS. Lorlatinib is a very potent ROS inhibitor. And Tesaro drug, Tesaro 011, also is a TRAC inhibitor. Alectinib is actually not a ROS1 inhibitor. So that's the one point to remember. Unlike crizotinib, seritinib, and entrectinib, lorlatinib, all of whom are, most ALK inhibitors are also potent ROS inhibitors. Alectinib is the one exception. It doesn't inhibit ROS, but it does have some RET inhibitory activity. And so now from the SPY, we have a variety of drugs now that we can use. And for ALK, we have several of these drugs. And like I said, I tend to start with alectinib or brigatinib and then study the resistance mechanism and before I figure out the next line of treatment. So in conclusion, cures remain elusive. We are not curing majority of the patients. Emergent resistance remains a problem. ALK-positive patients are generally non-responsive to immunotherapy. We know that single-agent immunotherapy responses to EGFR and ALK is only 3%. We know that from several retrospective studies. They're using chemo, use pemetrexed-based chemo, and consider local consolidative therapy after maximal response to targeted therapy. I think that's the last of my slides, and I thank you for your attention. Happy to take any questions.
Thank you so much, Dr. Simon. That was a great talk and was very insightful. And the resistance mechanisms were covered so beautifully. I'm sure all of us benefited a lot from this talk. I don't see any questions in the chat box now. Maybe we can take questions after Dr. Santosh's talk, maybe during the case presentation discussions. So moving on to the next talk. So now we have Dr. Santosh Devdas. He is an associate professor in the Department of Medical Oncology and also the chief of stem cell transplantation at MS Ramaya. And he is also a consultant with the HCG Ramaya hospitals, and he's trained at premier centers in India. And look forward to your talk, Dr. Santosh, on lorlatinib in the management of ALK positive advanced non-small cell lung cancer. Over to you, Dr. Santosh.
Thank you, Dr. Vishwanath, for that kind introduction. And most of the slides are probably kind of a repetition of Dr. George Simon's talk in some way, and I have a very not a very position of where I have to talk after such an elegant talk by Dr. George Simon. If there is a significant repetition, I'll just skip through the slides quickly. So this is my outline of the talk: a short introduction followed by mutation and inhibitors for ALK, and the need for CNS imaging in ALK mutated non-small cell lung cancer. A bit about the lorlatinib, which is a third generation ALK inhibitor, and the CROWN trial, which is a first line trial for ALK with lorlatinib. Lung cancer is, as we know, is one of the most commonly diagnosed cancer worldwide, and it is the reason for about 1 in 10 cancers diagnosed, and it's also a reason for 1 in 5 deaths world over. Non-small cell lung cancer constitute about 85% of all lung cancers diagnosed. And the overall survival for metastatic disease is only 7%. And the treatment is moving more from histology-based to targeted treatment. So the incidence of lung cancer is progressively increasing. In the next decade or so, we are going to have about 100,000 patients in our country and about 100,000 deaths that are expected to happen. The ALK rearrangement in lung cancer is one of the most commonly detected genomic change that can be targeted with an incidence of about 5 to 10%, and next only to the EGFR mutations. And it is typically seen in young non-smokers, and there are various diagnostic techniques that are available that was alluded to by Dr. George. And one thing to remember is the ALK and the EGFR mutations are mutually exclusive. This is how the ALK translocation happens on the chromosome 2, where there's an inversion on the same chromosome that was again alluded to previously. And how first, second, and third generation ALK inhibitors have been developed over the years. And recently, the US FDA approved lorlatinib in the frontline setting after the CROWN study. What is the unmet need in ALK positive non-small cell lung cancer? The CNS metastasis is a major problem. And up to 20 to 40% of newly diagnosed patients have CNS metastasis, which is a major challenge. And as spoken to just now, emergence of resistance to ALK TKIs is also a significant challenge in these patients. So there is a need for a drug that prevents the emergence of resistant subclones and improves CNS penetration. And both the NCCN and the ESMO guidelines do recommend a cranial MRI in addition to the other cross-sectional imaging at diagnosis. And many times it may or may not be feasible to do this additional investigation, especially in a resource-constrained setting. Various groups and investigators follow various ways of managing non-small cell lung cancer that is ALK mutated. One of the way of treating these patients is to use lorlatinib upfront followed by chemotherapy, or use first or second generation ALK inhibitors followed by lorlatinib in second line and subsequently to use chemotherapy. In a newly diagnosed patient with ALK positive non-small cell lung cancer, there is an incidence of brain metastasis in up to 20 to 40% of patients. The international guidelines recommend testing for CNS metastasis at diagnosis through cranial MRI with contrast. Several ALK TKIs have been evaluated in the first-line setting for ALK positive NSCLC for patients with baseline CNS metastasis that have shown significant efficacy. Lorlatinib is a tyrosine kinase inhibitor that is indicated in treatment of adult patients with metastatic non-small cell lung cancer whose tumors are ALK positive as detected by an FDA-approved test. In the first-line setting, lorlatinib has a potential to manage and prevent emergence of CNS metastasis in ALK positive NSCLC patients. Lorlatinib is an extremely potent ATP competitive binder of the ALK protein and has excellent CNS penetration. Lorlatinib has a potential to improve clinical outcomes with overall excellent intracranial activity in patients with previously untreated ALK positive advanced non-small cell lung cancer. In addition, upfront treatment with lorlatinib could completely suppress or at least significantly delay on-target resistance, leading to more durable clinical benefit. So it's why was lorlatinib is being pursued in the first line is because of its ability to prevent emergence of brain metastasis and its excellent penetration in the brain, and the plausible ability to eliminate rare pre-existing subclones and delay emergence of such resistant subclones. Lorlatinib in the first line was studied in the pivotal CROWN trial led by Dr. Alice Shaw from MIT. The key eligibility criteria included the presence of brain metastasis upfront, and patients were randomized in a 1:1 fashion, and the endpoints between lorlatinib and crizotinib, the primary endpoint being the progression-free survival by blinded independent central review committee, and the secondary endpoints were PFS, overall response, intracranial overall response, OS, safety, and quality of life. 296 patients were studied between May 2017 and February 2019, and all patients received cross-sectional imaging and brain image of the chest and abdomen and a brain imaging every 8 weeks. The median duration of follow-up for these patients for the initial readout was 18.3 months for lorlatinib and 14.8 months for crizotinib. And there was a long-term follow-up analysis that was recently presented in the AACR meeting, where the PFS median time for PFS was 36.7 months and 29.3 months respectively. Looking at the baseline characteristics, both lorlatinib and crizotinib were represented equally when we looked at various subgroups. If you look at the 18 months follow-up data, there was a 78% PFS rate compared to only 39% that was seen with crizotinib. And all subgroups benefited equally well. And the overall response rates was 76% with lorlatinib compared to 58% with crizotinib. Intracranial responses were also excellent, with 82% responses with lorlatinib versus 23% responses with crizotinib. If you look at the time to intracranial progression, lorlatinib hardly had any patient who progressed in the brain compared to crizotinib. The overall survival was similar. However, this data needs to mature further. If you look at the safety data, there was a significantly more grade 3, grade 4 adverse effects with lorlatinib. However, the adverse effects leading to treatment discontinuation was similar when compared to crizotinib. As alluded to previously, hypercholesterolemia, weight gain, edema, and cognitive effects were significant side effects that were seen with lorlatinib compared to crizotinib, which had more GI side effects, and bradycardia being one of the unique side effects with crizotinib. Looking at the quality of life, though the quality of life parameters were similar in the initial few months when lorlatinib and crizotinib were compared, at the 18 months time point, lorlatinib had a superior quality of life parameter compared to crizotinib. This is the 36 months follow-up data for lorlatinib that was recently presented. And even at 36 months, the PFS benefit was significantly different with a hazard ratio of only 0.27, which was superb when we compare with crizotinib. And all subgroups benefited. And if you look at the PFS in patients with and without brain metastasis, patients both with brain metastasis and without brain metastasis significantly benefited with the use of lorlatinib. And the time to intracranial progression was significantly longer with lorlatinib compared to crizotinib. And this was true both in patients who had baseline brain mets and the ones who didn't have baseline brain mets. Among the 112 patients who received lorlatinib, only one patient progressed in the brain at 36 months when they received lorlatinib, showing a significantly better brain activity in patients with lorlatinib. Looking at the responses, the overall response rates were 77% at 3 years with lorlatinib compared to 58% with crizotinib. And the ones with brain mets had a response rate of intracranial response rates of 83% with lorlatinib compared to only 23% with crizotinib. Looking at the overall outcome of the 36-month follow-up data, the PFS was significantly better with lorlatinib at 18 months with a hazard ratio of 0.28, which was 0.27 at 36 months. The overall response rates were similar at 36 months. And the intracranial response rates were also significantly better with lorlatinib, with the discontinuation rates of only 7% at 36 months when lorlatinib was used. Concluding, the 18 months of additional follow-up since the interim analysis of the phase 3 CROWN study, lorlatinib continued to show superior overall and the intracranial efficacy compared with crizotinib in patients with ALK-positive non-small cell lung cancer. The PFS rate was 63.5% at 3 years compared to 18.9% with crizotinib. The time to intracranial progression was longer with lorlatinib than crizotinib. The efficacy benefits with lorlatinib, both in patients with baseline brain mets and without brain mets, was significantly better. And only 1 out of the 112 patients had evidence of intracranial progressions if they didn't have brain mets at presentation. There were no new signals in terms of safety. And this led NCCN also to recommend lorlatinib as one of the preferred first-line options in patients with ALK-mutated NSCLC. One thing, again, one has to remember is to use statins, which do not have significant interaction in terms of CYP450 enzymes when patients are on lorlatinib, and to keep an eye on the CNS effects. With this, I end my presentation and thank you for the patient listening. Thank you.
Thank you, Dr. Santosh, for that very lucid talk on the role of lorlatinib in ALK-positive advanced non-small cell lung cancer. So shifting gears, we move on to the next session and the much awaited Meet the Professor session, where 2 of our DNB oncology fellows who will be presenting short cases of 5 minutes each, and we'll get expert opinions from Dr. George Simon. We invite you, Dr. George Simon, once again. And I'm Dr. Vishwanath, medical oncologist with the Apollo Hospitals, and I'll be moderating this session. So, Dr. Muthulingesh, can you over to you? You can present the first case, and Dr. Muthulingesh is again from Apollo Hospitals, Bangalore, and he's a DNB resident, first-year resident, very enthusiastic. So he's come forward to present this case. Over to you, Muthu.
Good evening, one and all. I would like to thank Vishwanath sir for giving me the great opportunity and going on to the case presentation. So she is a 74-year-old female with a known history of hypothyroidism. She presented with complaints of giddiness and headache on and off since 4 months. So she was evaluated with MRI. MRI was showing multiple lesions in brain, left frontal lobe, right parietal lobe, and cerebellar lesions, maximum size of 2 × 2 centimeter with moderate surrounding edema, suggestive of brain metastasis. On further evaluation, PET-CT was showing brain metastasis with edema and left lower lobe lung mass, which is of 6.8 × 4.7 centimeter with partial distal atelectasis, and as well as conglomerated enlarged left hilar mass, lower paratracheal and subcarinal nodes, as well as paratracheal node. So she underwent bronchoscopy plus core biopsy from the station 7 node, and as well as TBNA cytology, which showed positive for malignancy suggestive of adenocarcinoma, and the core biopsy from the mediastinal lymph node, which showed metastatic adenocarcinoma. So for the brain metastasis, she received palliative stereotactic radiotherapy, 30 gray in 10 fractions to all the 3 lesions. So on further molecular analysis, EGFR mutation was not detected, and PDL1 status was low, which is TPS score of 3%. And then ALK gene rearrangement, which was done by both FISH as well as immunohistochemistry, which showed positive. So she was, before the molecular testing reports came, she was started on chemotherapy with pemetrexed and carboplatin combination, and she received first cycle, and then we got up the reports with ALK positivity status. So chemotherapy was stopped, and she was started on ALK inhibitors with alectinib. So it was started with 450 mg BD initially, and she was tolerating well, and now she is on 600 mg BD, and she is doing well and asymptomatic with a good performance status. So her response assessment imaging with PET-CT and MRI brain is being done during the next week, 3rd week of August, and expecting a good response to treatment. So going on to discussion. Yes, sir.
Yeah. So Dr. Simon, the first question which we had was, I think you've addressed this very wonderfully during your talk, is between IHC, FISH, and NGS for ALK testing. So in your practice, how do you go about, Dr. Simon?
Yeah, no, this is a great question. We tend to do next generation sequencing, and we tend to do next generation sequencing in tissue. And so there are several things when you do next generation sequencing. There are some advantages, and of course there are some disadvantages. The main disadvantage of next generation sequencing is expense. It's expensive, and in resource constrained areas, you have to take that into account in your practice. And this was very elegantly done here. You diagnosed ALK positivity by relatively cheap test and immunohistochemistry, as well as FISH. The next-gen sequencing allows also to helps you in several ways. It allows you to detect the presence of other mutations, co-mutations, which may or may not be significant. And you have to have reliable next generation sequencing results. You have to have at least 25 nanograms of DNA. So generally, sometimes, unless you have a very good bronchoscopist, who is trained in a cancer setting to do biopsies with relatively thicker needles, sometimes it may be difficult to get the level of DNA that you would require from a bronchoscopic specimen. So in that situation, a CT-guided biopsy, where for next generation sequencing purposes, may be the desired way to go. So I completely agree with you here, because you really diagnosed this very cost effectively, I'll have to say. And the patient is benefiting from that, that approach that you took. I also agree with the choice of alectinib. It's a very potent tyrosine kinase inhibitor, ALK tyrosine kinase inhibitor. It has high CNS penetrance. If you had known that the patient was ALK positive, and if the CNS metastasis was asymptomatic, you could have actually started the alectinib and closely observed the brain lesions without radiation. And then you could radiate only the residual lesions, or if there was no response. So you could have potentially saved some money there, as stereotactic body radiation, brain radiation is expensive. It's an expensive tool. Now, the dose is an open question. In J-ALEX, the dose they used was 300 milligrams BID, the Japanese ALEX. And in the US dose, in the US, when I mean US, I mean North America and European dose is 600 milligrams BID. What is the correct dose for the Indian population? We don't know. I think this would be a prime area, easy question to answer. We could do a, countrywide, all the centers could come together and just do a simple trial, 300 BID versus 600 BID, which is more effective in the Indian population. And I don't know the answer to that question. I found it interesting that you started with the 450 milligram BID dose. We usually start straight with the 600 milligram BID dose and adjust the dose accordingly. Anemia has not been a major issue for us. Anemia of chronic disease is commonly seen. We monitor for that, but I've rarely had to intervene in any shape or form. Now, to choose between brigatinib versus alectinib versus lorlatinib, all three are options. All three are options. I prefer either alectinib or brigatinib. And not that I have anything against lorlatinib, it's just that I find that most patients have cholesterol going up to 700, 800, even triglycerides going up to 400, 500, 600, and all of them need statins. Many of them need high dose statins. And then you run into problems with statin problems, muscle pain, muscle aches, and that, even then, even some of the patients I've had in lorlatinib, even on high dose statins, the cholesterol don't really come down to normal. They still remain between 200 and 300, and they tend to have high triglycerides. The encephalopathy is a problem. That can be a problem. Peripheral neuropathy is a problem. Encephalopathy can sometimes, because many of the patients the patients panic. This is one side effect where the patients and family can panic very quickly when suddenly the patient started being encephalopathic. And I've seen limbic encephalitis. Often I've seen patient is almost comatose. We had to bring them into the hospital and stop the drug. It's not common, but it's common enough that I worry about it, And for those reasons, really, lorlatinib in terms of potency is just as potent or maybe more potent than brigatinib and alectinib. like Dr. Santosh pointed out, is extremely effective in the brain, and so is alectinib and brigatinib for that matter. And just because of a more favorable toxicity profile, I prefer to go with alectinib and brigatinib. And then sometimes I may try lorlatinib second line, especially if I see the G1202R resistance mutation, which only lorlatinib covers.
Great.
Those were some of my thoughts, and happy to kick it back to Indian
A few
physicians.
thoughts, Dr. Simon. So regarding this role of NGS at baseline, you did mention during your talk that the L1198F, which is only sensitive to crizotinib. So are we reaching a point where is it, again, we don't know if it's going to be there at baseline or it's an acquired mutation. So are we going to a point where, reaching a point where we do NGS and customize based on which ALK inhibitor to start with?
Yeah, so most of these mutations are resistance mutations and are not seen at baseline.
Okay.
But if you do see them up front, then yes, it should be, it would be good to consult the literature, particularly if you have a specific ALK mutation. Consult the literature and see whether there's any specific drug that would be beneficial. Anytime leucine is lost, with that one exception, lorlatinib is the drug of choice, but that tends to be be a primary resistance mutation. But again, if I do see I can't remember all these mutations. I remember the broad ones, leucine loss, G1202R. But if I see a specific mutation, I always consult the literature to help me guide which would be the best TKI in this setting. Great.
Just to give a perspective, the bioeconomics part in India. So we have a robust patient assistance program, and the cost of lorlatinib is around 1,20,000 rupees per month. And, the cost of crizotinib with the robust assistance program is as less as 42,000 rupees a month. And alectinib has also got a very good patient assistance program. It comes down to around 1.5 lakhs per month. So this is the average cost for the patient per month. I'm talking about all the three drugs which is available in India.
It's extremely costly. So alectinib is a little cheaper than lorlatinib?
Alectinib is little expensive as compared to lorlatinib. Lorlatinib is 1.25. Alectinib is around 1.5.
Okay. Well, if the patient in that setting, if the patient can afford it, then, but when you give lorlatinib, you also have to factor in the dose of the statin and the expense associated with that, especially if the patient is not already on a statin and some of the things. In that setting, you're to be totally justified in using, because even a 225,000 rupee difference per month is quite a big difference. And, lorlatinib could potentially be used as a preferred drug, given the cost efficacy.
In fact, Pfizer has come out with a very good patient assistance program for patients who are not able to afford this at all, who are below poverty line. They give crizotinib free lifelong.
I see.
Lifetime free. So that's a real nice initiative from them.
Yeah, I think, if that's the case, crizotinib is a reason, but if you can avoid it, don't use crizotinib, because I think it is significantly inferior to alectinib, brigatinib, lorlatinib. I mean, it's significantly inferior. But, it's obviously better than nothing in an oncogenically addicted tumor. And if that's the only choice, you can always start with that, and then meanwhile try to figure out how we can finance a subsequent TKI once resistance occurs to the crizotinib.
Sure. So also one question about the CNS penetration. I know it's you showed a wonderful table which had a cross-trial comparison of the CROWN trial, the ALEX trial, and the Crizotinib trial. Just that if you look at those pointers at the 3-year PFS, as well as talking about the intracranial complete response rates, though it is cross-trial comparison, lorlatinib is little better. It looks like it's little better as compared to alectinib. Any thoughts on this aspect? I know it's a cross-trial comparison.
Yeah. So in terms of response rates, it's not very different. It's all very similar. In terms of progression-free survival, yes, lorlatinib appears at first blush, again, to have a longer intracranial PFS than alectinib or brigatinib, that being said, these are all, these are not studies where you've compared these head to head, and there are, differences in how, how there are simple things can make big differences, like how frequently do you scan, right? If you scan every 2 months versus every 2 months or 4 months, the PFS will be different, right? Because the progression-free survival is dependent on the scan, and the scan frequency can affect the PFS. So simple differences like that can lead to differences in the time frame. I personally use alectinib and brigatinib because they are also very potent and very effective intracranial. You see very good intracranial responses. But because of the toxicity profile, I tend to prefer alectinib or brigatinib. But in the Indian setting, with the cost being a very significant consideration, I think lorlatinib is cheaper than alectinib or brigatinib, and really makes the case for starting lorlatinib and first and seeing how the patient tolerates. And if it's intolerable, of course, you still have the option to switch to another TKI at that setting.
Great. Dr. Muthu, do you have any question?
No, sir. Fine.
Okay, great. Thank you, Dr. Muthu, for that very nice case presentation. We'll move on to the next case.
Thank you, sir.
We have Dr. Abhinav Diwan, who is a DNB resident from Rajiv Gandhi Cancer Center in New Delhi. It's a real high volume center. And he's also very enthusiastic and come forward to present this very interesting case. Over to you, Dr. Abhinav.
Thank you, sir. Can you see my slides?
Yes.
Yeah, yes, we can.
Yeah. Good evening, everyone. Good evening, teachers, colleagues, and my dear friends. Moving on to the second case, dealing with second-line ALK-positive advanced non-small cell lung cancer. So here we have a 35-year-old female, ECOG performance score 1 with no comorbidities and no significant family history, who presented to our hospital with complaints of cough and weight loss of 2 months duration. PET scan was done initially, which showed a right lung mass abutting costal pleura with few heterogeneous subcentimetric lymph nodes. EBUS staging was done that was negative for N2 lymph nodes. MRI brain was normal, and patient proceeded with surgery and underwent lobectomy with systematic mediastinal lymph node dissection. However, final histopath came out to be PT3N2 adenocarcinoma, and it was a R0 dissection. So based on the histopath, patient underwent sequential chemoradiation and was later on kept on follow-up. On follow-up in May 2017, patient developed a recurrence, metastatic recurrence with upper paratracheal node, bony lesion. There were adnexal lesions and lung lesions also. We reviewed our slides, and molecular testing was done, which again was ALK positive. And in view of ovarian adnexal masses, basically we got the ovarian mass biopsy done, which was positive for TTF1 and P53. And it was suggestive of metastasis from lung primary. It was negative for WT1, Paxit, and P16, of course. And in view of ALK positivity, patient was started on Crizotinib 250 mg BD from May 2017. And sequential PET scans were done, and it showed maintenance of response. There was partial or stable disease. However, in February 2018, after almost 9 months, patient developed 2 discrete lesions, as we can see in this MRI, one in cerebellum and another in the right high parietal region. Following which, as patient was symptomatic, patient underwent SBRT for both the lesions, as we can see in this picture. And meanwhile, Crizotinib was continued. Response assessment was done post 3 months after SBRT, which showed partial response. And after almost 2 years of Crizotinib, there was progression in brain lesions, as we can see in this picture. This was the cerebellar lesion that has further progressed, and there were certain new lesions also. in addition to this new lesion, there was 1 or 2 more new lesions that had developed. So a PET scan was also done that showed stable extracranial disease. We took opinion from radiation oncologist, and patient was advised for whole brain RT. We discussed and gave options of both WBRT and alectinib to the patient and attendant. And of course, patient opted for alectinib, and alectinib was started in the dose of 600 milligram BD. And serial PET scans were done, which showed stable disease. After almost 1.5 years, almost 19-20 months, in March 2021, patient developed another new lesion, that is pleural thickening was there, which was biopsy proven, suggestive of non-small cell recurrence. And in view of progression, patient was switched over to lorlatinib from March 2021. Patient has tolerated, as we have discussed before, tolerated lorlatinib well. However, we have already discussed the side effect profile. Patient developed deranged lipid profile and was started on statins. Patient has been on 3 monthly follow-up, and last evaluation was done in April 2022, which is suggestive of stable disease. As we can see, there is some response in the brain lesions also, we can see in this picture, and the extracranial disease also appears to be stable. So if we just look at the timeline of events, Crizotinib we started in 2017 and used for almost 26 months, almost 2 years, following which we switched over in the second line to alectinib, which we continued for another 1.5 years. And after that, after progression, again, patient has been on lorlatinib, that is third line, and it is still 16 plus months and counting further. Thank you. And moving on to, without wasting further time, I would like to move on to discussion, and I would like to invite Professor Simon and Dr. Vishwanath sir to kindly proceed and moderate the discussion, sir.
Yeah, thank you so much for that wonderful case presentation, Dr. Abhinav. So, Dr. Simon, the first question over here is, do you regularly biopsy at recurrence and send for next generation sequencing?
Yes, I do. And again, you know, I practice in a relatively an affluent setting, and I do a biopsy, or sometimes I even do a liquid biopsy, ctDNA analysis. And a ctDNA analysis, you know, allows you to avoid a tissue biopsy, a liquid biopsy. And the key rule about liquid biopsy is, you know, often you can see ALK mutations in liquid biopsy, and there is a 90+% concordance between liquid biopsies and tissue biopsies. But the general rule is, in liquid biopsy, if it is there, it is there. But if it is not there, you may still have to look in the tissue. And so liquid biopsy is sort of a good interim, you know, way. But yes, normally I would do a biopsy of some sort, whether it's liquid or tissue, try to repeat the next-gen sequencing and help that guide the decision. That being said, the decisions made here are really great. You know, the patient has, you know, significantly benefited from the treatment approach that you have taken. Now, one of the things that you could consider is that if there is an isolated area of recurrence, like this patient had on alectinib, just that pleural-based mass, right? Then you could radiate that, and you could then buy the patient more time on alectinib, and it allows you to leave lorlatinib in your back pocket, okay? So if there is an isolated site of resistance, or what's called oligoprogressive disease, just one site of disease that is progressing, you can radiate that. And studies have shown in the EGFR setting that you may be able to buy the patient a median of another 6 to 9 months on the drug, on alectinib, you know, and you could extend the time on alectinib, leaving lorlatinib and other drugs in your back pocket. To answer the next question, what are the options after lorlatinib? You have several options. Obviously, if it is an oligoprogressive disease, you just radiate the sites of oligoprogression. I have seen that happen. I have seen that I've radiated one side, got 6 months, and radiated another side, got another area of metastasis, radiated that. And sometimes I've been able to, by picking off oligoprogressive areas by stereotactic radiation therapy, I've been able to keep the patient on the drug for several months, even over a year. There are other third generation very potent tyrosine kinases that are being developed. We talked about Exalt-3, the Crizotinib, Entrectinib. And there are other drugs, TPX-011, and that that have not gotten names yet. So there are other potent tyrosine kinase being developed, which could potentially be used. Hopefully it will be available in India through a clinical trial setting. And sometimes you do run out of these options. And if you especially see a transformation, which you will see, transformation to small cell or transformation to squamous cell, small cell much more commonly than squamous cell. And your suspicion for transformation should be triggered when you see sort of a plethora of progression, right? Suddenly the whole thing blew up, right? You got new metastases in lung, liver, bone. They suspect transformation. Another area is when you see next-gen sequencing, if you see both P53 and RB mutations, both the gatekeepers are lost. The G1S and the G2M and gatekeeper genes are lost. And they're, especially, as the vast majority of small cell lung cancers have 70 to 90% of small cell lung cancers have P53 knocked out, and 50 to 70% of small cell lung cancers have RB knocked out. So if they are both knocked out, then you worry about the risk of transformation. So that's something just to keep an eye on. This is where next-gen sequencing can help. If there is a rapid, aggressive progression, suspected transformation, that's just a small clinical clue. In that setting, what you do is you have to treat that with chemotherapy, whether it's a squamous cell component or a small cell chemo, or But then generally what I've done, and this is what I do, there's a little published literature on that, is I still continue the tyrosine kinase because there are some selective clones that are still oncogenically driven. And it may be, clinically challenging to give chemo and the TKI in combination. I do this much more in the EGFR setting where transformations are much more common. So, and then lastly, there is a study called IMpower 150 that looked at carbotaxol, bevacizumab, atezolizumab. And it's a large study, 1,200, 1,300 patient study, but they had about 117 patients had EGFR and ALK translocations, EGFR and ALK, and out of those 117, 83 had EGFR. So it's very small population of patients had, because I like to use pemetrexed-based chemotherapy. If you run out of TKI options, what I like to do is either carboplatin, pemetrexed. I don't use pembrolizumab or any other immunotherapy because it's not very effective in the EGFR positive or ALK positive setting, but I do sometimes use a anti-angiogenesis agent, either carbopemetrexed, bevacizumab. There is a phase 2 study going on in the US looking at carboplatin, pemetrexed, bevacizumab, atezolizumab, kind of along the lines of, and we have that study open here. So I tend to enroll the patients to that study. But that being said, I still think the most rational way of trying to, treat these patients is, first principle is pick off oligoprogressive disease with radiation whenever you can, and try to get as much time on your drug as possible. Number two, identify specific resistance mechanisms that could be targetable. Sometimes you'll find a MET amplification, and that is where I think, and if there is no clear targetable mutation, but you find MET amplification, you can go back to Crizotinib, because Crizotinib is a MET inhibitor and an ALK inhibitor, not as potent. Now, I've sometimes combined Crizotinib and Alectinib, which is difficult, two TKIs for targeting the MET and targeting the ALK better with the Alectinib. Though there are some situations where some of my colleagues have combined Alectinib with Tepotinib or Capematinib, some of the more potent and less toxic MET inhibitors. But sometimes when you're trying to combine two tyrosine kinases, it becomes challenging. You have to worry about QT prolongation, cardiac effects, CK elevations, lipase elevations. So some of those things you have to worry about. So really, situationally, and if you are, start with a good TKI, pick off oligoprogressive disease, and try to understand the resistance mechanism and try to tailor the treatment according to the resistance mechanism, which may not be possible all the time, and that may guide your treatment strategy to give, the maximum possible lifespan for your patients that you can. In the third question, role of TKIs in the adjuvant setting. So we now know from ADAURA that EGFR mutations, you can give osimertinib and you get a significant prolongation in progression-free survival, with the potential benefit in overall slight, but we have mature OS data not yet available in ADAURA. Those studies are ongoing in this setting. So there are studies called the Alchemist Trial in the US, where they're taking resected patients with ALK translocations. They're given their 4 cycles of adjuvant chemotherapy, which is the standard of care. At the time, Alchemist was designed. And then they're given an ALK inhibitor. First it was Crizotinib, and then it was modified to be Alectinib for 2 years. So the Alchemist trial is ongoing, and that will answer the question of the role of the TKI in the adjuvant setting. I don't use it right now. I just treat them definitively, and then hope that many of them don't recur. And if they do recur for 3, 4, 5 years, 3, 4 years down the road, then I hope that I can buy them some more time with the TKI, because those patients at that point would be TKI naive. But until those, the studies come along, I don't tend to use in ALK setting adjuvant ALK inhibitor in the adjuvant setting. The role of IO in stage 3 disease. Now, this is what you're saying is based on the Pacific trial. Pacific trial looked at chemoradiation followed by durvalumab, and in the durvalumab subset, if you look at the PFS forest plot in the paper, there was essentially no PFS forest plot in that paper because they had very few. But in the overall survival forest plot, there seemed to suggest that the immunotherapy seemed to benefit EGFR ALK positive patients as well. So I tend to use durvalumab in that. I still use durvalumab in that setting, but whether should we use an ALK inhibitor or durvalumab as maintenance therapy after definitive stage 3 treatment, that question is still out there. And we don't know the answer to that question. Until that data becomes available, I think I would stick with a Pacific-based treatment for now, and then reserve your TKI for relapse.
Great, sir. So we have some questions. We can quickly wrap it up from the chat box. So we have Dr. Oliver. He is a medical oncologist from Peru. He's a good friend. He rotated with me when I was in MD Anderson. And what is your experience using pemetrexed for advanced scenario, especially in patients who have previously received crizotinib and alectinib?
So the pemetrexed, you don't get, you do get responses, but you don't get prolonged responses. You can buy them sometime, 4 months, 6 months, but you're not going to get the responses like you see with alectinib, lorlatinib, brigatinib, 36 months, 39 months. But you get some brief responses. I do leave them on pemetrexed maintenance, and sometimes this is a setting where I tend to use bevacizumab with the pemetrexed whenever it's feasible, especially if it's a youngish male. Most of the ALK patients are younger males in their 50s with mucinous adenocarcinoma. So I tend to use Avastin with the pemetrexed and tend to use that in combination. But you don't get the kind of duration of response or progression-free survival that you would get with the TKIs. But once you've exhausted all those options, that's a reasonable approach.
In fact, it reinforces further after your talk and extremely tempting. So we have this Tata Memorial Center, they came up with a study where they used the gefitinib plus pemetrexed carboplatin that showed overall survival benefit. So it's very tempting because ours is a resource poor country, whether adding pemetrexed carboplatin to crizotinib. So we don't have data, but it's quite tempting in the clinical practice to use that.
Yeah, I mean, I think this is a setting where you can generate the data. You can have a simple phase 2 study where you give carbopemetrexed with crizotinib and generate the data. The data from Tata Memorial Hospital that showed an OS benefit for gefitinib plus carbopemetrexed versus gefitinib, that has been duplicated with, as the study has been done. It's called Flora 2. Flora 2 has been completed. Enrollment has been completed, and they are looking at platinum pemetrexed plus osimertinib versus osimertinib. That study has completed enrollment. We may actually be able to see some results by ASCO next year. But so that will sort of validate the. I'm pretty optimistic that's going to be positive, but we don't know. We'll see. But we'll know next year or by 2024.
Last few questions. What is your take on, it's again from the chat, what is your take on complementary testing, liquid and tissue in non-small cell lung cancer? You did answer this question, but
yeah, so let's assume that resources are not an issue, just pure scientific. All the testing is provided by the company free, okay? And in that, as let's say make that assumption, and you do say EGFR, or you have a patient with an ALK translocation with the specific mutation, right? You do a complementary, your side-by-side liquid biopsy, and it shows the presence of that mutation, whether it's EGFR or ALK or KRAS or whatever, right? And then you give your drug. For 2 months or 3 months. You see repeat a scan and you see a great response, right? Or a good response on the scan. Then you repeat a liquid biopsy and you show persistence versus no persistence in the liquid biopsy. That might have prognostic significance. So if you have persistent, so to go back to your question about crizotinib plus chemo, you could say, well, ours is a poor country. We can do a liquid biopsy. We'll see if we can get it paid for by the company, and then we find that we treat them with crizotinib first. We see a good radiographic response. We repeat the liquid biopsy, and we find that the ALK inhibitor is persistent. The ALK mutation that was initially diagnosed is detectable in the liquid biopsy, or even the fusion is detected by the liquid biopsy, 6 weeks or 3 months out. You could then say, well, I think we should now add chemo, so it's a research setting. It's a question that, there are some people I know from some of my colleagues in Penn do that in Philadelphia. They repeat a liquid biopsy and help serial liquid biopsies sort of help prognostication and also help guide for the treatment. But liquid biopsies are also very expensive, right? and they're also more fraught for failure. Tissue biopsies you can detect it reliably now, but liquid biopsies are more fraught for failure. So I think in big, large centers, all India, Tata, Apollo, Rajiv Gandhi, and others, I think it'll be good to study this in the Indian setting to see how this can be incorporated into the treatment algorithm, essentially to minimize cost, right? I think liquid biopsies may be, I don't know, 20,000 rupees or maybe 25. I don't know how much they cost. But when you're using a drug that is 1.5 lakhs, and if it could be not only help you guide treatment, but also reduce the cost for the patient.
Yeah, great. The next question is also quite similar. In which group of non-small cell lung cancer patients do you prefer liquid first approach?
Well, if there are two groups of patients where I do a liquid first, I mean, you could potentially use that approach in every patient, but there are particularly two groups of patients where I specifically prefer the liquid biopsy first. Number one is patient does not have an easily accessible biopsiable site. Okay, so either the disease is in the bone-only disease is an example, or brain disease, bone and brain disease is another example. Bone, when you can biopsy the bone, yes, and technically you can get the tissue, but when you get a tissue from the bone, you have to apply what's called a decalcification process, and the decalcification process damages the DNA, and then next gen sequencing may be difficult or a higher chance of failure. So inaccessible sites of metastases, bone-only disease, bone or brain-only disease, then in that setting, your liquid biopsy may be your only option.
The last question for the day, when a CML patient, chronic myeloid leukemia patient, develops metastatic non-small cell lung cancer with ALK mutation. Oh, I disappeared. I don't know, the question disappeared. Okay, now there's another question. I was reading it and it disappeared. I don't know. Okay, how frequently do you image for a reassessment for patients on first line Crizotinib and as well as on second or third generation ALK inhibitors? How frequent do you image?
Yeah. What I do is every 3 months, but for India, this is what I would say. For Crizotinib, I would do every 3 months because the median progression-free survival is 9 months. That's the median, right? So it could be 6 months even, or it could be 12 months, right? But with a very potent drug, one of the ways you could reduce costs is that the first scan you do in 3 months, right? In even 2 months to 3 months to show regression. And then once you've shown good regression, you can space out the scans to maybe every 6 months, right? Because the median progression-free survival is 36 months, right? And then at the 6 month scan, you can decide whether you want to go another 6 months or go down to 3 months. But in that setting, if you are on alectinib, brigatinib, lorlatinib, one of these potent tyrosine kinase inhibitors, you can reduce the frequency of the scans, both to reduce cost and inconvenience for patients.
Great.
I still would watch the brain more closely though, because the brain, but if the brain is not involved, you could essentially, after showing initial good response, you could just reduce it to 6 months.
That's great thought, sir. So I think that concludes our webinar. And thank you so much, Dr. George Simon, for sparing time in spite of your busy schedule. I think it was a wonderful talk and so much of insights. I mean, we've learned so much in this last 90 minutes. It's been just amazing. And we look forward to having many more meetings with you. And then, of course, Dr. Santosh, also my good friend and a co-organizer. And he also came up with a splendid talk. And then our DNB fellows, both of them, Dr. Muthulingesh and Dr. Abhinav, wonderful slides, good case presentation. I think this is the enthusiasm and zeal which you should have, and it'll take you, sky's the limit then. And then, of course, our attendees, including people from all over the world. I have a few people from Peru and other countries as well. They've joined, and this webinar is recorded, so it's going to be there. So Dr. Simon's talk is going to be there on recorded, and it's going to be there. And of course, our sponsors for today, educational grants from Pfizer Oncology and MedGenome, which is a next generation sequencing company in India. In fact, they do a great job as far as for the resources, especially patients who are not affordable. They help patients a lot. And thank you so much. And that concludes our webinar. Thank you so much, sir.
I want to say a quick congratulations to all my countrymen for the 75th anniversary of their independence.
Thank you so much, sir.
Thank you. Thank you.
Great celebration and joy. There's
Thank you.
Lots of things to be proud of.
Yes, sir. Thank you.
Bye.
Bye. Bye. Bye.